Let's talk about convulsive status epilepticus. So convulsive status epilepticus is a medical emergency, and it's defined as seizures lasting long enough to cause neuronal injury. It happens more frequently in infants and the elderly, and it follows a U-shaped distribution. There are many causes of status epilepticus, but the most common ones can include stroke, head trauma, infection, tumor, metabolic abnormalities, alcohol withdrawal, and medication non-adherence if they have previously been prescribed anti-epileptics. So the clinical features are very important because status epilepticus, if it's convulsive, is a clinical diagnosis. So it's defined as 5 or more minutes of generalized seizure or 2 discrete seizures without complete return to consciousness. Usually the patient will have a pre-existing diagnosis of epilepsy, so that'll be a clue. And that has the caveat that status epilepticus can occasionally be the first presentation of epilepsy. For treatment, this will actually start before evaluation even. So the airway, breathing, and circulation are the most important. These patients may need to be intubated to protect their airway, and they'll definitely need IV access. The first-line medications will be benzodiazepines for 2 doses, and most commonly that is lorazepam or midazolam. Second-line agents include valproate, levetiracetam, or fosphenytoin. If adequately treated, most patients will begin to recover consciousness by 20 minutes. However, if they do not start returning to baseline, then a continuous EEG will need to be connected to detect non-convulsive seizures. So a little bit under half of patients who have status epilepticus that is convulsive, once they stop having convulsions, they'll still have non-convulsive seizure. The EEG can also be helpful in differentiating between more refractory seizures and psychogenic seizures. A CT head is done urgently to rule out hemorrhage or other focal deficits, and a lumbar puncture is also indicated if you are concerned for infection. So other parts of the evaluation include checking for metabolic abnormalities, including sodium, calcium, magnesium, or glucose derangements. If glucose is low, thiamine is given with the glucose. Liver function tests are important. This can change which medication you give. CBC is also important because you may be concerned for infection, and a urine tox screen is important because some medications, or rather drugs, such as sympathomimetics, can cause seizures. So the levels of any home seizure medications can be drawn to see if the seizure happened due to medication noncompliance, or if the patient is actually having status epilepticus on top of their pre-existing epilepsy while being therapeutic on their medications, which may require an increase in their home medications. A non-urgent MRI brain can be done later on to pick up smaller lesions. For prognosis, the mortality of generalized convulsive status epilepticus in adults is about 20%. Status epilepticus is also a risk factor for recurrence of the status, and about 20% of patients in status unfortunately will also develop refractory status epilepticus and may need further medications.